Great. So today I am joined by my guest, Dr. English. How are you today?
I'm doing well, Dr. Huntley. How about you?
I'm doing well. I'm doing well. Looking forward to chatting with you and learning more about your journey uh, into public health and all the work that you're doing. So let's just start with you. Just tell us a little bit about yourself.
Sure. So I actually grew up on the East Coast in Connecticut and into a family of pharmacists. So my family actually had a local pharmacy for generations. And growing up, I made the decision to go to college to study to become a pharmacist. And I did. I went to the University of Iowa, became a pharmacist, and while I was at Iowa, I had an opportunity to accept an internship with the Indian Health Service. And so I spent the summer with the Ojibwe up in Red Lake, northern Minnesota, working in the pharmacy there for several months, and really enjoyed the experience. Quite different from growing up in a small town in Connecticut, working in a retail pharmacy, to working on a Native American reservation. And following that summer, I went back to school at Iowa to complete a variety of internships to finish up my degree. And upon completion, I had an opportunity to complete one more internship out in Zuni, New Mexico, with the Zuni Pueblo. And so I actually spent 6 months in Zuni, again, working for Indian Health Service, working with one of the Pueblo communities here in New Mexico, where I am today, and really, again, enjoyed the experience and enjoyed it so much that after graduation, I accepted a position as a clinical pharmacist working with Indian Health Service.
Oh, wow. That's pretty fascinating. I know a few pharmacists that have gone back and gotten um, a public health degree and have been doing various things to merge, kind of fill the gap and merge. I think it's interesting that you worked in Indian Health Country as a pharmacist. I'm really curious, just kind of briefly, I'll ask you now, how well received? How did you engage with the community as a pharmacist? Just knowing that sometimes traditional medicine and the view and the definition of medicine is very different. In the Native community. So, how was that role for you to be specifically an Indian Health Service?
Yeah, so sort of a multi-component answer to that. So I'm not Native, I'm Caucasian, and at the time that I took the first internship, I was quite young. I was in my early 20s, and so this was a new experience for me for sure. So as I took the initial internship and was residing in the tribal community, working in the pharmacy, one of the things that I really enjoyed about the way pharmacy is practiced within Indian Health Service and also now within tribal health facilities, it's a more comprehensive approach. So we were, with every prescription, also receiving the patient's medical record. So you were able to really do a little bit more of a review, more applied clinical pharmacy work in filling the prescription or working with the providers to make sure that we had the right prescription. But then the piece that I enjoyed the most was that we had consultation rooms. And so when folks did come in to pick up their medications, we actually sat together and talked about the medication. And again, being new, not being from the culture, this was a two-way learning process with every encounter that I had in the pharmacy. And it's something that I really enjoyed about the work. So while I was sharing information about medicines and the pharmaceuticals that we were dispensing, I was also learning quite a bit about the community members, and again, what you're talking about, sort of the intersection of traditional and Western medicine. So it was a tremendous learning opportunity for me, and that is what has led to a lifelong career now in working now in public health, but still working with American Indian communities.
Right. Oh, love to hear that. I like that setup. I wish that was the norm to have the, consultation or consulting room, and to have that kind of approach. That would make such a difference because I know that most people are turning to their pharmacist to really understand their diagnosis and their medication, their treatment, because they leave the doctor's office often with a lot of questions still. So I wish there was more of an opportunity like that. Um,
Absolutely. No, I agree completely. Yeah.
well, I'd love to hear the journey. So let's before we get too much into what you do now, let's kind of go back a bit and kind of continue. You dabbled and touched on it a bit with you know, the family of pharmacists, but when did you first learn about public health or become interested in public health?
Yeah, so it really was while working with Indian Health Service. So pharmacy has evolved since then, and it does have more of a preventive lens to it. But at the time, we really were focused on treatment. And so, as I mentioned, I was in the consultation room, I was talking to folks, and in many cases, dispensing medication that was for treatment of conditions that were preventable. And, when you're going to school and you're learning about these therapies, you realize they're very effective. And it is great that we have, excellent treatments for many medical conditions. But it sort of stuck with me that there's probably more that we could do upstream. There was more that could be done preventively. And it felt like perhaps I was on the wrong end of the overall sort of continuum of healthcare, being on the treatment side instead of more upstream in terms of, disease prevention, health promotion. And so I got hooked up with a group within the clinic I was working at that was focused on diabetes prevention. And they needed a pharmacist to come and talk about medications at their various events. But I also learned some of the hard work that they were doing around data, around education, communication, really looking at those structural conditions that were contributing to a disproportionate amount of type 2 diabetes, completely preventable. And that got my interest a bit more than working with the metformin and the insulin on the treatment side. And that really spurred me to pursue a degree in public health. And I haven't looked back since. I have continued to practice pharmacy, but really more as a secondary career, with public health and prevention now being the focus of the work that I do.
That's awesome. Um, and I like the way you frame it too, with that kind of shift maybe to prevention. Of course, we need to still have that focus of treatment for the people that are where they are, but really being able to target the prevention opportunities. Really like that. So, can you describe more in detail what you're doing now?
Sure, I'm happy to. So now I serve as the director of one of the 12 tribal epidemiology centers in this country. I'm based in Albuquerque at the Albuquerque Area Indian Health Board, and I direct what we call ASTEC, and that's an acronym that stands for the Albuquerque Area Southwest Tribal Epidemiology Center. So we're based in Albuquerque. We serve 27 tribal communities in a 4-state region. And you would think with a name like Tribal Epidemiology Center, our focus would be exclusively on epidemiology and data, but it really is much broader. We do we focus on all things public health. And so within, the language for, defining what a tribal epidemiology center is, there's mention of 7 core functions. And we do, we operationalize these 7 core functions in our center every day. And so they're focusing on things like collecting data and public health surveillance, which you would expect when you hear the word tribal epidemiology center. But they also include translating that data and more applied work, technical support for the communities that we serve, more translational work, looking to partner with tribal communities to make recommendations based on the data, getting involved in health promotion, disease prevention interventions, evaluation. So really, when we look at our 7 core functions, you could say that they're really also very similar to the 10 essential public health services. And I've looked at this in the past, and I realize the work that we're doing really can be considered, in full alignment with those 10 essential public health services. And most important is that we're in service to the 27 tribes in our region. And so on a day-to-day basis, we have a good sense of what we're working on, but We also recognize that those needs and priorities change, and our team is positioned to respond. So when new public health concerns emerge or when new ideas are sparked, we jump in. And for the last 3 years, our center has been heavily involved in the COVID-19 response in partnership with many of the tribal communities in our area, as well as the State Department of Health. As tribal epicenters, we are public health authorities. So our center has been involved in doing case investigations, contact tracing, case and contact monitoring in partnership with more than a dozen of the communities in our area. We do situational reporting to try and get out meaningful data and information to our tribal partners. We've been developing culturally centered communications products that translate the data that we're seeing and the important public health recommendations. We've actually been grant making. So even though we're recipients of grant funding to do our work, we've also in the last decade or so become a grant maker where we're actually providing funding directly to the communities that we serve to strengthen their resources to operationalize the work and the public health activities that they have prioritized for themselves. Even recently, we've started a tribal COVID-19 vaccine hotline where we've trained navigators to serve as operators to essentially field calls from community members or any partners who have questions about the COVID-19 vaccine, who's eligible, who's due, where you can find it. And that has, evolved into an even broader hotline that essentially responds to any COVID-19 related question that's out there, including things like disseminating COVID-19 tests. So we've had a very diverse portfolio of work for a number of years. And these last 3 years have been, sort of like we've all taken on a second full-time position where we have really jumped in and worked alongside of the communities that we serve to best respond to the pandemic throughout our region.
That is very, like you said, a diverse portfolio of work. It sounds like an incredible amount of work. I'm sure you've got, like most of the techs that I've spoken with, and a very dedicated team that wears many hats and is flexible, which is, I guess, the nature of how you serve, and with not just the diverse programs, but also the community and the population. Um, are you able to describe, you mentioned I think you said 4-state area. Can you describe the population that you serve and maybe some of the, primary public health problems that you target?
Yeah, sure. So we're working with 27 tribal communities. The majority are situated in New Mexico. However, our region of service does expand up into southwestern Colorado, southeastern Utah, and West Texas. Um, 27 tribal communities, a very diverse and heterogeneous population that we serve, with many unique strengths. When we all come to work together. One of the, I think, most rewarding elements of the work that we do is the fact that we get to build relationships and partnerships and learn more about the various strengths and assets of the communities that we serve in terms of culture and language, beautiful lands, resiliency. So this is the population that we've been serving and that we continue to serve. We also have what we call an executive council that meets on a quarterly basis and guides our work. It's comprised of a tribal leader or a tribal health administrator from each of the 27 communities. And at our last strategic planning session with this executive council, they identified some core strategic priorities for us to really focus on. And that's been the key focus of our work. And they came up with behavioral health, chronic disease prevention and control, injury prevention, and healthy aging. So we try and make sure that all of the work that we're doing is tapping into one of those 4 core strategic priority areas, which they have identified as important concerns for their communities.
Thank you for that detail and for explaining that. I've been having this conversation about tribal sovereignty when I speak with each of the techs, and this council that you just described sounds like a really great structure for, you know, I guess respecting that and holding space for that. Um, is that the purpose of that, or is it just happens to work out that way?
It's of course one of the key purposes of it. We want to make sure that everything we're doing is in alignment with the key needs and priorities of the communities that we serve. Without question, we want to honor tribal sovereignty in all of our work. And I'm sure other techs have also talked to you about Indigenous data sovereignty. Again, we want to make sure that the communities that we serve are in the driver's seat and that they are the ones who are letting our team know how to make sure that everything we do is aligned with important cultural considerations and is respectful of that sovereignty and honors it.
Yeah, that's important. Learning more and more. I've been hosting these special conversations on the podcast for a few years now, and I learn more and more each time I have this conversation around tribal sovereignty, data sovereignty, and all the challenges that are in between. Um, in your own words, well, before I move on to that, let me ask you this. Is there a particular urgent or critical need for um, access to this quality public health data? Is there anything that we could dive into a little bit more deeply?
Yes. So I think probably the most important thing and the number one request that we receive from tribal leadership is tribe specific data. So
Mm,
there is an ask for high quality and representative data that is meaningful for the tribes that we serve. And, this has been our greatest challenge, but it's also where the most promise lies in that tribal epicenters are working every day to try and work with the existing data that's out there. So, we are set up in this country to have really good public health surveillance, or at least our public health surveillance systems are designed to focus on national data, state level data, and to maybe a lesser extent, small area data like county level data. But when it comes to tribal jurisdictions, in many cases, I think our public health surveillance system is failing, um, sovereign nations in that data is not readily available. It may not be collected, or if it is collected, it's collapsed into other groups, or it's too small to utilize. And it's often, when it is available, not shared. And so I think tribal epicenters, we are uniquely positioned to enhance access to good data, to enhance quality of the data, to make sure it's representative, and to try and pull together data that is tribally specific. Because at the end of the day, tribal leaders have to make decisions based on information. And without information that's specific to them and to their community and their population, it's very difficult to do that. And so we've engaged in a number of different techniques, whether it's collecting primary data within tribal communities in partnership with tribal communities, oversampling into existing public health surveillance systems, creating our own tribal public health surveillance systems, conducting data linkages to try and either add in data like tribal affiliation or correct for racial and ethnic misclassification, geocoding. Been engaged in a number of methods and approaches to make our best effort to create and produce tribe-specific data that really is meaningful and actionable for tribal leadership. And that's really at the heart of what we're trying to do.
So, is there you mentioned a lot of methods and a lot of strategies, and this is something that I hear this challenge often. So, I do a lot of consulting work with the tribal communities, and this is something that I also consistently hear. So, of the strategies that you've mentioned, you guys have tried a lot of them. Is there any one or two that are really more beneficial or impactful, or that you tend to repeat that work better than others? Um, just curious, does anything stand out as being more helpful?
I mean, right now, essentially, it's been a combination of all of these strategies sort of working together to then hopefully in the end triangulate and get what we're looking for. I think that we've been successful across all of these methods, and I can't say that one or two are standing out over the others. What we're hoping, though, is that we're setting an example of how it can be done so that, larger public health systems, state departments of health, the CDC are able to take some of this work on.
Hmm.
At this point, tribal epidemiology centers, we are funded to do this work, but not funded in any means in the same capacity as these larger public health institutions. And, we feel like it's important to be working together. We want to continue to be the leaders in this work. But at the same time, I think that we really need to make sure that there's an investment in, really striving to provide sovereign tribal nations with their own data through our public health surveillance system throughout this country to beef up the infrastructure and make sure that the data that tribal leaders need is available. We'll continue to do that work. We can be the leaders in it. We need to be resourced to do it. As you can imagine, our teams are not at the same level of workforce as the CDC or state departments of health. But the passion is there, and we are having great success. So at this point, I can't say that there's one of these strategies that has, a prevailing benefit over the others. I think it just requires us working on, all of these simultaneous to produce the best data that we can.
Yeah. So do you think that, so let's put on our hypothetical hats in an ideal situation, wonderful world. Do you think that it would be ideal or optimal for some of these larger agencies like CDC and state departments of health to incorporate some of the strategies that you've been using at the tribal epidemiology centers on this broader scale, sort of getting ahead and moving, looking in the, instead of correcting for what has already been, kind of looking ahead into what we're going to be doing? Do you think that that would be an ideal strategy?
For sure. Yes, I think that's what we all want to see, right? It is the best data possible, from all sources. Right now, if you go, let's say, to a national website and you're looking to, find some, let's say, American Indian specific data for a county, oftentimes it'll, the only value that's there is, NA, or,
Mm-hmm.
there isn't, even a field there. And in some instances, it's the data, not enough data has been collected. In other instances, it's that, race wasn't collected or hasn't been made available. And so, when tribal leaders are looking at surveillance reports, and if their population isn't included, it makes it extremely difficult to do good public health work and to align your priorities with the needs. And so at this point, I think all of us have a duty to try and do more to optimize the availability and the quality of the data that is out there. I know we can do more. We're through Tribal Epicenter showing that there are successful strategies that can work. It takes a lot of partnership, a lot of political will, and just a lot of manpower to produce. But in the end of the day, it's worth it, and it's in my opinion, all about equity at this point. And
Yeah.
communities need that information, and we're positioned to provide guidance and support and leadership. And we just are asking for all other partners to join us in that.
Yeah. I would really love to see uh, these strategies implemented across other communities of color and other minority communities that have just been um, under, I would say, erased, or kind of, clumped into the other category or not
Mm-hmm.
properly identified. So um, there's a lot of work to do, but every now and then I like to put on that hypothetical hat and think in an ideal world and just, spend a few moments there envisioning how it could be. Um, but we'll keep hoping and keep doing the work, and we'll keep having these conversations.
For sure.
Absolutely. Okay, so we have a very broad, diverse group of people who listen to this podcast. We have students, graduates, we have uh, career folks of all different levels, entrepreneurs, and then folks that are just curious about public health and are just listening to get familiar. So I would love for you to just take a moment and help kind of connect the dots. We can all look up a definition of epidemiology, but I like to hear the more applied and practical kind of what it means to you. How do you describe epidemiology in your own words? And, and how is it important in the work that you do, the community you serve?
Sure. Yeah, so Dr. Huntley, as you can imagine, when I'm presenting to tribal leaders and I keep saying the word epidemiology over and over, it occurs to me that, maybe that word is not one that all of us use on a regular basis. So, I've always thought, what is the best way to break it down and explain exactly what I'm talking about? You could say the science of public health, but even that I think is still pretty vague. And so if you just, break the word into its parts, essentially it is the study of what is upon the people. And I think that resonates. So that has been sort of the way that we define the science of epidemiology. It's the study of what is upon the people. But at tribal epicenters, that's part of it. And so that's where I'm sort of getting at this sort of broader lens that we come from in our work. Across all of the essential public health services. So we do want to know through data, what is upon the people. But at the same time, what we really want to do is make sure that we're working alongside of the communities that we serve to translate what that data means in whatever manner the community determines, and then work together to either translate that information into meaningful priorities or to actually turn it into decision making, policy making, program development, research to answer some new questions that have emerged from the data. So that's sort of how we think about epidemiology. We absolutely are always, involved in the practical application of it. We don't want data reports to sit on the shelf. We don't want them to not be meaningful. So all of the work that we do is to make sure that not only is the information produced, but we're helping to sort of answer the question of either so what or what now, because we feel like otherwise we're almost doing a disservice. So luckily we're in a position that we're able to, as I mentioned, go beyond just, the data piece and actually work in this more translational capacity, and, work together to drive action.
I like that. I wrote down what you said. I really like that. The study of what is upon the people. I'll give you credit, but I'm going to be using that.
I don't think I don't think I'm the one who came up with it either.
Oh, this is such a great conversation. I'm learning in it so much and really enjoying. I appreciate you taking some time to be here. And I just have one more question for you as we sort of wrap up. Again, considering the diverse audience of listeners that we have to this podcast, I always try to think about what they would like in a takeaway. So I'm just curious, do you have any advice for someone who's listening and maybe interested in working with tribal communities?
Oh, sure, absolutely. So again, going back to our executive council, we also have a board of directors with our organization, the Albuquerque Area Indian Health Board. And I have been in this position now for almost 20 years, not with the Tribal Epicenter exclusively, but between the Tribal Epicenter and other work with our organization. And what I've heard over and over from tribal leadership is that their priority is the next generation. And so one of, I think, the most sort of prioritized elements of our work is our student development program. We really see it as our charge to help develop the next generation of American Indian public health professionals. And so within our organization, within our epicenter, and I know within all of my colleagues' centers as well, we have student internship programs, student development programs. At our center, we have internship opportunities in the spring and fall semesters, as well as the summer. And our priority is to bring American Indian public health students into our team to work with us on a project throughout the internship period. Many of our interns repeat for a second term or a second semester, sometimes even longer. I can tell you that today we probably have 5 to 10 of our full-time staff who were at one point or another interns at our center. And the same is true for my colleagues in other tribal epicenters across the country. So if folks out there are students and they're interested in learning about internship programs within tribal epidemiology centers, I would encourage you to go to our shared website, which is tribalepicenters.org. That is where you can be linked to the various employment opportunities as well as student internships within each of our centers. So that's sort of a clearinghouse of that information. Or if you're looking within a certain region, you can go to the individual websites. We have one as well that will talk a little bit more about our student internships, our timelines, application process, et cetera. But we found that to be probably the most beneficial way for folks to learn more about who tribal epicenters are, what we do, and if it's the right fit for you. But as I mentioned, tribal leaders, they want one of our main functions to be to strengthen and build the public health infrastructure within the tribal communities that we serve. And so one of the ways we can do that is to try and spur interest in public health within young people in those communities, as well as providing opportunities for scholarship and for applied work through our centers.
That's wonderful. I know you got some ears perked up when you were talking to me, when you were mentioning that. I know my listeners, and they are either thinking about it for themselves or thinking about how they can share the information. So I'll put more details in the summary of this episode, and also links in the show notes for everyone listening. Thank you again. This has been a great conversation. I appreciate your time to come and chat with me about all of this and in the work that you're doing. Just sharing your journey. It's been really inspiring for me listening to you, and I know for others listening as well. So I appreciate you.
Well, thank you. Thanks for the opportunity.